Priyanka, do you want to comment a little bit on how we're testing patients who've already had CDK4/6 inhibitors versus not in the SOLAR-1 trial, and then next steps?
Sure. So, one of the things that happens always in our field is, new drugs and data comes along, but where we put it in our patients in clinic today doesn't match the trial design. In SOLAR-1, majority of patients did not receive CDK4/6 inhibitor in first-line setting with aromatase inhibitors, which would be considered current standard of care. And we're applying alpelisib to second-line setting. And so we need studies that mimic the current population that we're treating in clinic. And, BELIEVE is one of the trials that's looking at CDK4/6 inhibitor progression and the efficacy of PI3 kinase inhibitors. In my practice, I'm testing for PIK3CA mutations early on first-line setting on CDK4/6 inhibitor, just because, as we know, it's a fairly conserved mutation. So I'd rather have that information available when I need to make this change, but we do need the data of how efficacious this combination is when patients have received contemporary first-line endocrine therapy plus targeted therapy.
Yeah, we're really looking forward to the data from BELIEVE to try and help us understand benefits, although it's a single-arm trial in patients with PIK3CA mutations who've had CDK4/6 inhibitors. One other question I think that's probably of interest to our audience and to all of us, John, is if a patient has had ctDNA testing and you don't find a PIK3CA mutation, how do the payers approach then getting NGS from the tissue?
Okay, so your question is, if they do circulating tumor DNA and don't find a PIK3 mutation, would we pay for a repeat tissue biopsy and a solid tissue? That's not a common, I know that's an issue, but I think the important thing there, at least to my understanding, is to test people with circulating tumor DNA when they're progressing. If there's no evidence of progression, there may not be circulating DNA being sloughed into the bloodstream for sampling. But if the guidelines indicate that a patient might be appropriate for a therapy and the only way to get that tissue would be through a repeat biopsy to pay for it, I think the big question though is how many markers do you need to look at? If you just need one marker, it could be a single gene test as opposed to next generation sequencing where you're sequencing hundreds of different genes. The other time that we would pay for a next-gen panel, whether it be through ctDNA or through a tissue biopsy in solid tissue next-gen sequencing, would be if a patient was eligible for a clinical trial. Now, payers differ there. Certainly Medicare would cover a test in that situation, and they would certainly cover the clinical trials. Not all payers cover testing to determine whether or not patients are appropriate for a clinical trial, but we've said if we're going to cover a trial, we need to cover the tests that are appropriate to determine whether or not a patient is eligible.
Yeah, I think that's a really good summary of what we're thinking about and what the payers are thinking about on both sides in terms of what you can do. You mentioned single gene testing on tumor tissue. We generally only get that when we send it to a sponsor rather than when we send it on our own. Claudine, have you sent single gene testing?
I tried, and it was maybe the last time I tried, it was about 6 months ago. So I recognize the world changes, but it was I couldn't get single gene testing, sort of, hundreds of genes or just nothing when you're sending off next generation sequencing.
Yeah.
I think the cost relatively is kind of similar actually for some of our sponsors in terms of, our partners in the laboratory testing area. The cost is relatively similar to getting one gene versus many, actually.
Yeah. Well, in fact, the cost of the testing itself compared to the cost of these drugs, I try not to remember the cost of the drugs, but the CDK4/6 inhibitors are $10,000 more a month. So the cost of a single test, either circulating or solid tissue, is on the order of $2,400 to $3,000. So it pales in comparison to the additive cost of treating a patient month over month with an expensive therapy. So it's a good investment to make sure that the patient is appropriate for a given therapy.
Great. Thanks very much for your participation in this discussion. Really interesting. And I think an area which is changing sort of on an ongoing basis. So it'll be interesting to see what happens in the next year with more data.